thank you all. Thank you all very much for having me, for David, for inviting me. I'm really deeply honored to be here as the Gaines Foundation Visiting Scholar in Medicine and Humanism this year. It's a privilege to visit this campus, to visit your city, which I'm learning how to pronounce properly as Louisville. Did I do okay? Okay. I had a lovely stay at the Brown Hotel, that magnificent building, and I'm really grateful to Sharon Bauer and Callie Booth for their administrative support with this visit. As Dr. Dukas said, we met,
Before we go on, actually
this microphone is better?
The other one is the internet mic.
Oh, okay.
There you go.
Great. As Dr. Dukas said, we met, I couldn't say when, at professional meetings a long time ago. I've known him over the years as a passionate medical educator with a deep understanding of the value of ethics, professionalism, and the humanities in medical education. My remarks today have emerged from participating in his Academy for Professionalism in Healthcare conferences these last 2 years. These conferences engage experts from around the world in high-level conversations about the challenges of defining, teaching, and assessing professionalism in medicine. My thinking today originated at last year's conference and has evolved since then into a kind of an exploration of the where and how emotion plays a role in medical practice and medical professionalism. This is a vast topic. My remarks will only touch on a few aspects of it. But I'm going to argue, ultimately, that emotional self-awareness ought to be considered a professional competence. I'm going to begin with the definition of professionalism. This, as I said, is difficult to define, to teach, and to assess. It includes individual attributes, which you in medicine recognize well, the behaviors, skills, and attitudes, which I'll recognize more in a moment. It includes interpersonal capacities pertaining to relationships with families, patients, and medical staff, largely focused around communication and the kind of therapeutic alliance one can develop. And it involves institutional cultures. It's hard to think that individuals can be professional if institutions do not support those values and commitments. But institutions, as we know, can promote or inhibit those values, behaviors, and commitments that we hold dear in professionalism. So I want to start by looking at the ACGME competencies of professionalism. Look at these and notice how many of these include some affective or subjective component: compassion, integrity, respect for others, responsiveness to patient need, respect for patient privacy, accountability to society even, sensitivity to a diverse patient population. All of these include to some degree an element of emotion. But why focus on emotion now? Well, my first answer to that is because it's implied in these professionalism competencies. Second, because it's neglected in medical culture, where emotion is often seen as disruptive. I will add that it's often also, or for the most part, neglected in medical ethics, where we rely on reason, on abstract principles for the most part. But the most important reason I think we need to think about emotion today is because of the widespread reports of emotional distress among our healthcare professionals. These include medical students, residents, and physicians. We've got multiple publications just in this year on mistreatment of students, residents, and nurses. I think 5 in this month's academic medicine alone. We've got widespread reports of disrespect of patients, families, and medical colleagues. We have reports of burnout, lack of fulfillment, and attrition in our healthcare workforce, including large numbers of people who are choosing to retire early. This alone should be reason enough for wanting to look at emotion in medicine. But my argument today is going to focus on 3 areas of medical practice. I'm going to draw on advances in cognitive sciences and behavioral psychology to explore the role of emotion in clinical judgment and moral decision-making. I'm going to look at the role of empathy in the physician-patient relationship, where emotion serves as a resource. I should say, in the first, emotion can be seen at times as a risk to clear decision-making and judgment. And third, I'm going to explore the high costs of emotional exhaustion and burnout on the workforce to argue that emotional health and self-care are a kind of professional responsibility. So there are my three topics today. Along the way, I'm going to take you on a little trip to Prague, a city known for centuries as a wellspring of artistic, literary, and musical accomplishment, a city I had the good fortune to visit this past year and was delighted for the diversity of ways in which human expression was visible in public art everywhere. So you'll get a little taste of that. I'll begin with three views of emotion. First, as a physiological response to stimuli, we can think of emotion as a kind of universally experienced element in our biological and neurological processing. We can think of emotional intelligence as the ability to recognize one's own emotional state and to discern in response appropriately to the emotions of others, including patients, including colleagues, and faculty. Ideally, we recognize our own emotions and are able to understand what they're telling us and control them as needed. Emotional health is a kind of a goal of feeling emotionally secure, a state in which emotional feelings, both positive and negative, can be safely recognized, experienced, and expressed without deleterious long-term impacts on individuals. Emotional health, that sense of security, recognizes emotions as transient feelings that come and go, rather like the weather. We're aware that emotion surfaces in medical practice in many, many ways. These top three in bold are the areas I'm going to look at, but we could just as easily look at how emotion impacts our sense of self-confidence, our initiative, our curiosity, where we find meaning and fulfillment at work. Leadership styles. There are so many different ways of being a leader, and we know that how we express ourselves emotionally makes a huge difference. How we engage with others as members of a team has a lot to do with how we express and experience emotions. Emotions impact learning styles. They inform our gender identity, our role expectations, how we can balance work and family, and many other ways. I'm sure you can think of many right now. A little caveat here. I do not want to diminish in any way the value of emotional detachment in medicine. It's clearly necessary for effective clinical and moral decision-making, for establishing and maintaining appropriate boundaries with patients, colleagues, families, and it may contribute to emotional resilience and self-care. So emotional detachment has its place, but I'm going to argue here that recognition of where emotion serves medicine is equally important. I want to start with how emotion informs decision-making. That emotions contribute to judgment has been recognized since antiquity. But in recent decades, Antonio Damasio, a neuroscientist, and his colleagues have demonstrated that reason is not a freestanding cognitive capacity, but intertwined with lower forms of neurological processing, these lower forms that regulate feelings and emotions. These forms of processing have links, they argue, to every bodily organ, such that emotion, feeling, and biological regulation all impact reason. In order for people to make decisions effectively, these linkages must be intact. And I'd invite you to think for a minute how often the first clue that you're witnessing or involved in an ethical conflict is some sense of emotional distress. It might be anger, frustration, grief, sorrow. It might be just that yuck factor. But it is some emotional signal. We need to be somewhat emotionally sensitive to even apprehend we're receiving that signal. Arguably, those who are so detached from their emotions might not be as sensitive to ethical values around them. They also might not be as aware of their own emotional distress and need for self-care. But I highlight this here to say that emotional sensitivity can be very informative, not just of moral issues, but of how your patients are responding to you in any kind of human interaction. Today, however, the notion that the best judgments are those that are based exclusively on reason is still widely held. What's hard to perceive and accept, I think, for most of us, is that often the first step in our making what seems to us a rational decision or judgment comes from our emotional reaction to whatever the situation may be. And that's something I want to highlight today. How many of you are familiar with Daniel Kahneman's work, or maybe his latest large book in which he summarizes his life's work, Thinking Fast and Slow? Anyone? Okay. Kahneman goes on, he builds on the work of Damasio and others to distinguish between two kinds of processing, what he calls dual process theory, to distinguish between fast and slow thinking, both of which are operative with us to some degree all the time, although he would argue that fast thinking is the dominant means of processing and dominates perhaps up to 95% of the time. Fast thinking is automatic, effortless, and non-rational. It often occurs without our conscious awareness, and it cannot be turned off. It's on all the time. We can't turn it off. Why that's important is because it influences judgment all the time. It influences how you react to others all the time. It cannot be turned off. It consists of our emotional reactions, our intuitions, our biases, conscious or subconscious, and the use of heuristics. I'll go into that a little bit more in a minute. Is this microphone working? I'm getting a little bit of a buzz up here.
Might pull it back away from you a little bit. It's pretty sensitive.
Okay. Fast thinking is our default processing mode. I should say that those emotional reactions and intuitions are informed by experience, by our knowledge, by our associations, by pattern recognition. And that we bring all of our past experience, our personal psychology, our values to our fast thinking, which is why fast thinking is in some way unique to each of us. But is our default processing mode. And because of the fact that it is unconscious, informed by subjective, non-rational factors, sometimes called predictable irrationality, it is considered unreliable, distorting of necessary clinical judgment, and vulnerable to error. As such, it's rarely discussed in medicine, in medical education, and although we're seeing more of it now in the medical literature, this is relatively new and it's still relatively rare. By contrast, slow thinking takes deliberate, conscious effort. It has to be turned on. This is what we know as rational analysis. This kind of rational analysis governs those acts of will, those acts of impulse control, self-discipline, and hard work that we hold dear in medical practice or any professional endeavor. It's considered, because we're aware of it, we know what it's based on. It's considered less vulnerable to error. And it's assumed normative in medical education and practice. Actually, studies have shown that both fast and slow thinking contribute to optimal decisions. If you think too deliberately, too long, you wind up making more mistakes than if you use some fast thinking in your judgment. So there are studies that look at how long it takes someone to arrive at certain medical kinds of decisions, and the ones that take longest are more prone to error than ones somewhere in the middle. The instant fast thinking is also, those based on intuition are also prone to error. Reason, I want to point out, is bounded. Reason has its limits. When we're faced with situations in which information is not fully available, we don't know all we need to know, or information is uncertain, or the situation is completely unfamiliar, or so complicated that it exceeds our capacity to process it and come out with an answer in the end, we talk about bounded rationality. Bounded rationality is important because when we're faced with a decision that must be made and reason can't get us there, then we turn to our fast thinking and rely on intuition and heuristics. So, how does fast thinking work in clinical and moral judgment? I want to go through some of these different ways, assuming that you're not familiar with them, although you're working with them all the time. Tacit knowledge is a term coined by a philosopher named Michael Polanyi decades ago. It refers to the fact that we often know much more than we can say. I recognize a face. I don't know why I recognize a face. This is his classic case. How do we recognize a face? I can't describe to you that face in a way that would help you recognize it too. But I know more than I can say. And we use this all the time. How we read behaviors, how we read your attention right now, how you recognize and interpret clinical signs and symptoms. Tacit knowledge is something that experienced physicians use all the time. When they're working with familiar conditions, if they were to take the time to go through rational analysis of all these tests they're doing to come up with the same answer, it would take them forever. We rely on physicians using fast thinking when they're experienced enough to do that. Novices, medical students, need to get there. They need to build that structure of reasoned analysis and knowledge to get there over time with practice, with seeing many patients. Every patient you see is informing a large database, and you can draw on that database in your fast thinking once you have filled it enough and have that experience. That's what tacit knowledge refers to. We shorthand it, we call it intuition, but intuition really refers to, in practice, pattern recognition. What Kahneman talks a lot about, though, is how we use cognitive and emotional biases and heuristics in medicine. And this has been studied more. Kahneman talks about it in the abstract, and he used that to inform this whole field we now know as behavioral economics. Pat Croscari, who's I think at Dalhousie in Nova Scotia, has published widely on how this kind of thinking informs medical practice. Again, he speaks of the use of biases and heuristics as using these predictable deviations from reason, from rationality. There are over 100 of these he's identified in medical practice. I've mentioned a few here. Hands, are you familiar with these? Yes, some. Well, let me just mention a few. Availability refers to how quickly an idea or an image comes to mind. Classic one. I say shark. You're too young, many of you, but many people would say Jaws, the movie. You know, you don't think about fish in water, but you have an instant association. That's what's available to you. That instant judgment is going to prejudice how you think about sharks in the immediate future. Anchoring refers to the notion of how long you've believed in something, how deeply rooted that belief is. My personal example here is that I lived for years, I have congenital high cholesterol. So I've been avoiding eggs forever, and I gather they're not so bad for us now, and so I try to eat them, but it's sort of, I have to overcome a hurdle to take in eating eggs as a healthy thing. Representativeness. For many lay people, they hear the word cancer, and the one person they know who's had cancer stands in for the whole broad spectrum of all the people they know who've had cancer, or who could have cancer, and the range of experience that cancer can mean. But they latch onto that one experience they know and assume that that is the experience that whatever this new incidence might contain. Confirmation bias is when a physician, say, is proceeding on the path of diagnosing someone and they close out their thinking early, eliminating further exploration of whatever might be going on because they're certain that they've got the right diagnosis, and then they use only that information that confirms that diagnosis. They don't look what additional non-confirming information might mean. They look for that information that confirms what they think they're looking for. Overconfidence, simply in the states of uncertainty, I'm more comfortable relying on my judgment of how to respond to uncertainty than somebody else's. That's just a built-in bias. I don't want to be in the control of someone else who doesn't understand this situation any better than I do. And anyway, these kinds of cognitive biases are common. We can't turn them off. They're based on our experience, our knowledge, our emotional associations, and they're ever present. Some of them are based on cognitive information. Others are based on emotions, whether they're innate or learned. We all have emotional responses, reflexes. So I grouped them here together. Both are operative in medical practice, in decision making, both moral and clinical. I would just say that in moral decision making, we can latch onto a particular priority, be it a value, a principle, a religious belief, a role identity. We can lock into any one of those things, and that can govern what we think is the right thing to do. The heuristics are just as common, in other words, in moral decision making as they can be in clinical decision making. For these reasons, they are, I consider, a risk. Because they're non-rational, If we rely on these heuristics without being aware of what we're doing, if we let our emotions govern our decisions, which this is going to happen unless we're aware of it and control for it, we are making decisions that are not based on defensible information. I would just mention here that bioethics hasn't yet cottoned on to this. There are a few people who are writing in this, but the fact that most of bioethics is based on abstract reasoning, which is very much dependent on logic, on deductive argument. It doesn't really know what to do with the fact that emotion is setting the template for whatever argument may follow. In fact, for most of us, the idea that what we do is we react to a situation with an emotional response and only justify it retrospectively. I see an ethical situation, my emotions tell me what the right thing is to do, and then I justify it accordingly. Other sources of fast thinking, though, include implicit learning. We worry about this with our medical students who have both the formal curriculum and the hidden curriculum, and the hidden curriculum is full of biases that we don't articulate, but that impact how they, for instance, stereotype certain types of patients. I have an example of this in just a minute. Other sources of bias include contextual factors. If you're only given so much time to see patients, that's going to almost force you into fast thinking. If you're exhausted, if you're faced with uncertainty, there are many different factors that contribute to fast thinking that are beyond your personal control. Other endogenous conditions include depression, fatigue, an individual's cognitive load, other stresses going on in their life, what unpleasant thing or pleasant thing just happened to a person. These can all impact how you respond to that patient in front of you. Then there's all the what we call dysregulation. That would include excessive emotional involvement with patients, maybe some of the rescue fantasies or sexual attractions, excessive detachment even, inappropriate anger. When emotions are not appropriately regulated, we find physicians getting into trouble. But again, that's more fast thinking causing these problems. Here's my example of where the hidden curriculum can make a difference. I found this study recently. It was a study of medical students, residents, and practicing physicians that revealed that all carry negative attitudes toward senior patients, informed by both the formal and the informal curriculum. The biomedicalization of aging was argued fosters a view of aging as a process of inevitable decline, disease, and irreversible decay. It's a losing battle. In the hidden curriculum, the negative attributes associated with old age included a limited or absent future, patient's loss of identity, depression, dementia, patients being non-productive parasites on the state because they're drawing Social Security or Medicare, and patients as lonely, isolated, asexual, and uninteresting. Caring for such patients was perceived as unsatisfying. Curing is more rewarding than caring or maintenance. Geriatric patients were furthermore perceived as complex, time-consuming, expensive, that took extra care that physicians were not always compensated for. Despite all of this, students and residents recognized that they had wonderful relationships with senior patients that they valued, that their patients valued them. They had positive experiences with their senior patients, but the messages conveyed to them through the overt and hidden curriculum were such that their attitudes were largely negative, and one can imagine their specialty choices rarely included geriatrics. Just as an aside, one of the articles in Academic Medicine this month speaks to how students are judged by their expression of preference, choice. I see some nodding. And I just mentioned that to a small group of, this is late in the third year, of internal medicine clerkship students, and they said, oh yes, this is widespread. They get hammered if they say they want to go into family, or immediately dismissed as less than, interesting to residents. Well, that would depend on the specialty, but internal medicine, surgery, this is where the residents are very hard on them. apparently psychiatry is lower than neurology. They gave me a whole priority list. Anyway, it was discouraging to hear that what I was reading about is widely experienced in my school of medicine, suggesting that implicit learning is profound, and the kinds of stereotypes that were coming up with in that class strongly discouraged primary care, something we need very much right now. So we need to be aware of how implicit learning works, and counter it whenever possible. Given what we know about fast thinking, it would seem that we need to try to control for it in clinical practice. Now, we do a lot for error management as it is, but we focus largely on procedural errors. Those are the easily seen correctable ones. Cognitive errors we can get at sometimes in retrospect, analyzing judgment calls in retrospect, but errors in fast thinking are very difficult to detect, even in retrospect, and take a great deal of mental discipline and effort, at least now, while this notion is so unfamiliar. I would like to think that if we worked at this, we would get familiar with how fast thinking works, where to look for possible biases, and learn to control for them. But right now, we don't do this. Ideally, if we did, what it would take is an awareness that risks of bias are unavoidable due to all these influences I discussed, some prompt or cue that a decision merits examination or reconsideration, and this might take many different forms. Something reminds you that you missed including some information. Some contextual circumstance, maybe you didn't have time. Maybe someone was ragging on you to hurry up, or some family member was pressing you. Some contextual circumstance that may have skewed judgment. That your relationship with a patient, maybe you recognize that you really liked, or the opposite, this patient, that made you wish for certain things. That ego bias, the idea that my outcome with this patient is going to beat the odds. Because I really care for this patient, let's try this. Never mind the fact that the outcome rate is really statistically poor. When you really care about a patient, you may do things you wouldn't if you didn't have that clear detachment. Again, if one's aware that one's emotions are stressed at the time of a patient encounter, you might use that as a signal to go back and take a look at how this decision was made. Even if you're willing to do that, to go back and look at how that decision was made, the hard work is just ahead, because you still need to be able to inhibit your fast thinking while you do it. And your fast thinking might be overwhelmed with guilt, with anxiety. What if I screwed up? What's going to happen? All this fast thinking that you can't turn off is going on. You need to be able to slow it down and say, okay, what really happened here? And that is not easy. It's certainly not reinforced right now. So I would just offer some questions to ask, to try to make habitual, would include simple ones like this. Why am I thinking this way? Am I neglecting anything? Any information the patient has told me? Any data point I might have? What else does this situation remind me of? What patient similar to this patient might be governing my thinking? What is uncertain? If I have great uncertainty, I should know that I'm going to have to be using fast thinking, or I might want to fill in the blanks with fast thinking. How is this patient making me feel, and how is that impacting my judgment? That should be easy. We can all do that in our interactions with others. How am I responding to this person? Am I glad to see him or her? Do I feel safe in their presence? Do I feel anxious? How does that impact my judgment? What else might this be? A really important question that ought to be a habit anyway. Is there another way to interpret this situation? That's a simple one for any kind of clinical judgment assessment. I would just say that learning to ask these questions is an initial way to try to draw emotional self-awareness to one's own attention and perhaps protect against error. It is for this reason that I would, in this area, in clinical judgment, that I would argue that emotional self-awareness is very important. I'm going to move on now to look at emotion in physician-patient relationships. But that's the one way in which emotion can constitute a risk, of which we all need to be cognizant and adapt appropriately. Moving on to emotion in relationships. In medical practice, you're all very aware of how many different ways emotions can materialize in relationships with patients, whether it's through relationships of high regard or compassion, the way we project our own needs onto patients, these desires to rescue, to heal, to be appreciated, grief and frustration in response to patient deaths or medical mistakes, the desire to avoid patients who are suffering or their families, anger at non-adherent patients, patients who appear to be self-destructive or manipulative, difficult patients, patients that take time, and cynicism sometimes resulting from dysfunctional health systems or a sense of futility. I get this a lot with psychiatry clerkship students, believe it or not. And lastly, that fear of patient litigation that can lead so many to defensive practices, emotions present in these and many other ways in relationships with patients. But I want to focus on one, on empathy, which is the most frequently mentioned attribute of humanistic physicians. This involves the cognitive ability to understand another person. It involves three aspects, actually, the cognitive, affective, and behavioral aspects, starting with the cognitive ability to understand another person's inner experiences and feelings, to view the world from his or her perspective, and to be able to communicate that understanding with the patient. This is intellectual work. Can I think about how that other patient is feeling? Can I communicate this understanding? Whether that intellectual understanding is joined with an affective, a genuine emotional connection can vary. But genuine empathy implies some willingness to join with the patient in his or her emotional experience, to fully understand what they're going through. And this can be behaviorally expressed in how one cares for the patient. Empathy, an empathic response to a patient, sometimes occurs spontaneously. Often it does not. You can't will yourself to be empathic, I would say. We can suggest that one ought to be empathic in response to patients, but you can't force yourself to be empathic. However, you can choose to be empathic. You can choose to be curious, to inquire about that patient, to learn as much as you can, and sometimes from learning, genuine empathy can grow. Sometimes not, but if not, at least you've demonstrated an interest in a tangible way. But because it takes effort in choosing to inquire, in choosing to do that work, empathy can be considered emotional labor. Scholars of human resource service professions have noted that, have called this kind of emotional work, that work where you have to override sometimes your genuine emotional state, as a kind of labor, because it takes overriding your fast thinking, overriding all that automatic stuff, to try to take an interest, to be empathic, to care. Choosing to care when your emotions are telling you to detach or not to care, or this is a difficult patient who's making you really angry, to choose to be composed, pleasant, attentive, demonstrate respect, that takes self-discipline. That takes effort. That takes fast thinking, real effort. If that effort is made, though, studies suggest that outcomes improve when patients feel their physicians understand them. That is, their fears, their expectations, and their illness beliefs. I would refer you all, if you're interested in empathy, to an excellent book by Jodi Halpern. She's done a really thoughtful analysis of what contributes to empathy, what it takes from a physician, how patients respond, the clinical evidence on that. Outcomes do improve with empathic relationships with one's patient, with one's physician, and that failure to connect empathically detracts from effective care, leading to poorer outcomes. Sometimes that failure to connect means that you don't ask the necessary questions about your patient. You make all kinds of stereotypic, sometimes assumptions, and sometimes misdiagnoses in the process, which results in return treatments, misdiagnoses, and higher costs of care. But the work of empathy can count as labor. We all know that prolonged witnessing of suffering is depressing, it's exhausting, and it can result in a tension between the desire or the need to empathize with patients and the desire for self-protection. So human service work, whatever it is, maybe it's retail, maybe it's working for airlines, maybe it's medicine, whatever it is, human service work includes the need to be able to regulate one's emotions in the interest of providing quality care. I turn now to this notion of surface and deep acting in a literature I found in nursing. Never seen this in the medical literature, but nursing is full of this, as is human service occupational literature. Surface acting refers to the notion of adhering to professional norms, providing that professional demeanor despite one's true feelings. That is to express courtesy, respect, and attentive listening. It takes effort to override one's genuine emotional state, though, and if prolonged, that effort, as I described, can lead to exhaustion. So surface acting is what most of us know during the day. It's how we behave appropriately with others. It may not reflect our inner state at all. We do it, though. The argument here is that surface acting in difficult, stressful conditions, as is so common in medicine, surface acting can wear you out, leading to burnout. Deep acting, by contrast, involves realignment of one's felt emotions and one's expressed emotions, resulting in a more genuine emotional response. That is to say, I'm faced with this difficult, angry, upset patient. I can do the surface acting, which takes effort, or I can stand in that patient's shoes and try to understand where they're coming from, and if so, my attentive listening may be much more genuine. Interestingly, deep acting has been found in this literature to be associated with more positive personal and organizational consequences, including increased job satisfaction, improved job performance, and decreased job turnover, much less burnout. Deep acting, it seems to me, the languages are very different, but it seems to me is very similar to empathy, that effort to realign and experience what the patient is feeling so as to feel with them and learn from them more genuinely. This is not a simple dichotomy. There's a lot left to learn about how surface and deep acting work. They can occur simultaneously, as in, if I'm feeling for you very greatly, but I need to communicate something else. Or they can occur in rapid succession, even with the same patient in the same encounter, as in, I'm only doing surface acting as you're telling me all this stuff, but when you tell me something more with which I really resonate, my feeling shifts to one of deep acting. Arguably, people at any point in a day or with any different individual, they're going to vary in which mode they feel more comfortable or in which mode they use more often. I would just say that there's a lot more to learn about this, and certainly a lot more to learn about how we can use surface and deep acting in healthcare. The fact that deep acting seems to be the more sustainable, the least taxing of the two approaches, suggests to me that it's necessary to learn how to use our emotions as a resource, that our emotions are our friends in patient encounters. They're not something to repress, to box off. If we can learn to use our emotions to align with patients, we may come away feeling much more fulfilled and much less exhausted over time. It's a weird idea, I know that, because this culture of detachment suggests that you need to box your emotions off and forget about them. They're there all the time, though. If you can learn to use them in your encounters, it takes a real shift of how we train ourselves. If we can learn to use them, though, there may not be as much exhaustion as we have today. The question is, how do you cultivate that empathic regard? And I can't answer that question. Again, we need more research. But arguably, the expression, the willingness to express, to feel emotions, to recognize, articulate, and respond to emotions can be reinforced or impeded by the behavior of others, by the role modeling we see, by the institutional messages we get. You know, when we have hospitals that talk about their commitment to patient-centered care, what does that really mean? Does that mean a 5-minute appointment or something else? Let's figure that out. Let's embrace that and see if we can work with that in fostering sincere emotional connections with our patients. You might need to begin with surface acting, this sort of fake it till you make it thing, and I think most of us do that. We learn good manners. We learn to communicate courtesy, respect, attentive regard. In doing that, we develop habits. And those habits obviously relieve some of the stress of making the effort to override our genuine feelings. The habits are helpful. We want to cultivate habits for when we are unable to genuinely make the shift to empathy. Keep those habits coming. They are a rock. But, acting training also. You're not going to get a lot of support for acting training in medical school unless you have a strong humanities program. But acting training teaches this very thing. It teaches how to take the perspective of another in a genuine way. When I talk to my colleagues who teach acting at my university, I am just so sorry I failed to take acting class way back then. I'm one of these people who's stage shy. I would never have gone there. But what you learn about emotional intelligence, how to express emotions, how to take the perspective of another with whom you are at substantial odds as a person, has got to be extremely helpful in something like learning deep acting. The rewards of deep acting, of genuine empathic connection with your patients, are going to be felt in that effective therapeutic reliance, in your patient's regard, and in those better outcomes. That alone could be self-motivating. So in cultivating empathic regard, that could be a help. But this is really about substantial culture change. I know that. But that is the way in which I referred to emotion as a resource. It is something that is there for us. It's on all the time. We can learn to use it far more effectively than we currently do. I'm going to turn now to burnout. Burnout is typically measured in Maslow's burnout inventory, which has a variety of questions, about 20 questions, that explore the surveyees, emotional exhaustion, one's feelings of being overextended and exhausted through work, the degree to which a person has depersonalized the patients that they're supposedly treating, and one's sense of personal accomplishment, to what degree one feels satisfied or fulfilled in one's work, as opposed to a sense of futility and exhaustion. In a recent study, symptoms of burnout were reported by about 50% of medical students, slightly less for early career physicians. This is the most recent study I've seen, but others in the last couple of years suggest that burnout is experienced, or reported anyway, by up to 70% of physicians. I don't have data here, but I've seen it on the numbers of physicians that are pursuing early retirement options. But we have a problem today with our workforce, and this we cannot afford. So burnout is something to be taken very seriously. Contributing factors are both individual and contextual. Some of them have to do with the types of people who choose to pursue medicine in the first place. And these are all good things. They're type A personalities, they're high achievers, they're committed to excellence, they tend to be workaholics, they want to make a difference, they want to heal, they want to help. They're competitive, they do fear failure, but that helps them excel. Okay, some may wind up being somewhat narcissistic. There is some sense of entitlement out there. But another factor that contributes to burnout seems to be prior victimization as a medical student. How that works, I cannot say, but it's in the data. Contextual factors are more serious, or at least as serious, and can be attributed to the hierarchical nature of healthcare, high workload demands, the medical culture that rewards individual achievement and self-sacrifice, high exposure to suffering, high exposure to stressful and emotionally demanding interactions that include ethical conflicts, an increasing sense of decreasing professional control, the sense that professional autonomy is being whittled away, and little or no institutional support or attention to our healthcare professionals' physical and psychological safety. This is a cultural problem. The consequences of burnout are felt by students, physicians, and patients. They are not good. For students, depression, addiction, diminished empathy, interest in caring for the underserved, increased attachment, increased cheating, dishonest clinical behaviors and negative attitudes, and the desire to leave the profession. Students saying by the end of their 4th year, I wish I were doing something else, but I can't get out. For physicians, the list is long. Professional loneliness, the loss of a sense of meaning and purpose, the sense of failure or self-blame, guilt, feelings of cynicism, helplessness, hopelessness, frustration. Depersonalization of patients again, anger or contempt for patients, feeling victimized by patients and clinical demands, increased risks of depression, disruptive behaviors, again, see this month's Academic Medicine. Demeaning remarks to students, residents, and nurses this month. Passive-aggressive behaviors. Interesting pieces, couple pieces in the last couple of years by Lucian Leap on disrespectful behaviors across the medical culture. And reduced productivity, health, absences, and early retirement. For patients, the concern is the greatest. Consequences of burnout for patients include less good care, poor clinical and ethical judgment, inappropriate use of healthcare resources, avoidance of patients and families, the difficult patient, the suffering patient, the time-consuming patient, poor communication, abrupt or non-communication, just not telling people what they need to know, difficulty giving bad news, dismissive or belittling remarks, loss of patients' trust and confidence, suboptimal outcomes, of course, and then litigation. So in this time, I've tried to talk about how emotion is a risk, a resource, and most recently a responsibility. I would say emotional self-awareness is a professional responsibility. To make the case that we need much more of emotional self-awareness across the board in medical education and practice. In clinical practice, we obviously need it for sound clinical judgment and ethical judgment, our awareness and control of the influences of fast thinking. In the physician-patient relationship, how we use our emotions to develop those relationships is something that self-awareness can greatly support and facilitate. And lastly, emotional health is essential to earning and maintaining the public's trust, to inspiring and transmitting professional values to the next generation of physicians, and to avoiding burnout. Emotional self-awareness is key to all of these. We have no language for this yet, we have no institutional support for this yet, but if nothing else, what's happening to our healthcare providers and our patients as a consequence, due to lack of regard for our emotional lives, merits this new attention. But if emotional self-awareness is so critical, how do we get there? And I just have a few suggestions in these three arenas. In clinical judgment, I think we first need to acknowledge that fast thinking is on all the time. We need to look at where it's useful and where it poses risk to safety and optimal care. We need to make it visible. We need to talk about it. We need to train our students in how fast thinking works, the kinds of heuristics, those hundreds of heuristics that Kroskeri has identified that can influence clinical judgment. We need to talk about how it also influences moral judgment, and the typical places could be on rounds, in discussions of decision making, in developing differentials, in morbidity and mortality rounds. There are many places where we could just automatically build this in to create new habits of thinking. We need to learn to anticipate where and why emotion and intuition can positively and negatively influence clinical decisions, behaviors, and judgments. And most of all, we need to learn to question our own judgment as a habit. In physician-patient relationships, again, showcase emotions as a resource, as a contributing factor, and learn to recognize how one is responding as an automatic response, to check in. How am I responding to this patient? Appreciate the value of empathy as it could contribute to a relationship and contribute to a strong therapeutic alliance. Learn about or understand the difference between surface and deep acting, and consider where each is appropriate, necessary, and when to use which one. Arguably in patients that you're only going to see for these 5 minutes, you may not need to empathize greatly if the need is a simple one. But knowing that you have this resource at your disposal is a kind of emotional self-awareness. And recognize, lastly, most importantly, when one is so emotionally stressed or exhausted that one is on the verge of burnout, that one's stress could be impacting patients and colleagues, even families, and seek help. This slide is a little bit redundant. I'm drawing here on some of the findings that I've seen in the literature on self-care. The self-care literature strikes me as inadequate because it's all about things you can do to try to take care of yourselves. You know, starting with healthy habits and a balanced lifestyle. The notion that if one spends at least 20% of one's time at work doing valued activities, one will avoid burnout. That is a kind of depressing finding. Recognize when you're sick. Physicians and students are famous for working through sickness. This is a kind of machismo thing in medical culture, but recognize when you're sick. Treat yourself as being sick. Take care of yourself. If you can't take care of yourself, how can you really take care of patients? Don't work through illness, and take vacations. Vacations are good things. And also, don't disparage counseling support. You need to find the right one, but don't disparage it. Promote changes also in institutional cultures to promote a physically and emotionally healthy workforce. So those were some of the kinds of approaches that you'll find in the literature recommending self-care strategies. I want to turn now to some of the other strategies found in medical humanities programs and other kinds of efforts to promote self-care. These are strategies, all of which have been tried across the country. There's little data proving their efficacy, but I just want to put these out there. Training in mindfulness and metacognition. Mindfulness teaches one to be aware of what's going on in your body. Where are you holding tension? Why might that be? If you can trace that back, you might discern something of what's going on for you emotionally. Metacognition is the exercise of learning to think about how you make decisions, thinking about thinking, which can, again, what I was asking or recommending way back about the questions to ask following a clinical decision, that is metacognition. What is influencing my thinking? Why am I thinking this way? Reflection, widely recommended, individually, in groups, in response to literature, in response to patient narratives, in response to cases you've encountered. Reflection is an incredibly valuable way to integrate what one is experiencing with some self-understanding. Typically, students and practicing physicians are zooming through days, just dealing with the demands at hand so quickly that there's almost no time to integrate what you've experienced, what has happened, and to make sense of it in the sense of, how is this important to me? Do I care? Am I fulfilled today? Or am I exhausted and unhappy today? Reflection can get you there. Writing really helps. Talking it out doesn't demand the same kind of organization that writing does. Writing compels a narrative. Yeah, you can do the sort of creative free writing people do before breakfast in some places. Even that will do it. Even that will do it. But writing demands, for those of us who've, all of us here, been trained in writing, a subject and a verb. You need to think in narrative forms, and those narratives will help you understand yourself. Schwartz rounds are a kind of a program that have been pursued in hospitals across the country. Over 300 hospitals have gotten funding to do Schwartz rounds. These are interdisciplinary panels that get together on a scheduled time once a month to talk about difficult cases. They're open to the public, and the public is invited to chip in with their responses to that case and or similar cases for themselves. It's found cathartic as those in the audience learn that what they're experiencing is experienced by others. They also learn respect for others in the health team. And then there's engagement with the humanities, and a full discussion of this, I think, is going to await our next half hour. I would simply argue that while we've incorporated as we can humanities into the medical curriculum, I think there are more ways to do it. We can use our responses to literature, for instance, to learn about our loyalties, learn about where our emotions feel most connection. We can learn about ourselves through our responses to literature, to art, through how we respond to an image. Deep examination of a work of art requires a kind of intellectual dedication that eventually will lead one to one's sense of emotional response. It's not something most of us are familiar doing. I would argue that we've kind of lost our visual intelligence skills over the millennia. But developing those to learn how images can prompt emotional responses can be a very valuable tool as well. History tells us something about how all narratives are situated. They include and exclude certain information. that teaches us a form of critical analysis and how to interpret also others' narratives, be they patient narratives. To really understand that narratives are, by definition, biased expressions of a perspective. Philosophy and ethics, as you know, they can teach us something about the different values and frameworks we use to guide our moral judgment. They can also teach us to examine the tool, why is this principle or framework preferable to another? So there's much more to be said about that. But in conclusion, I've argued that the contribution of emotion to clinical and moral judgment, the physician-patient relationship, and the health of our medical workforce necessitates the development of emotional self-awareness as a professional competency. How this can best be done is still unclear, but there are many possible strategies and approaches that are being used across the country. I recognize that this calls for substantial culture change that will not be easy, but I don't know that there's an alternative. Given what we now know about the role of emotion in healthcare, to expect anything less would be, in some way, I believe, to fail both our patients and our medical profession. Thank you. May I just say, if you're interested, there's a bunch of references here. Yes?
It occurs to me in listening to this presentation how valuable it is if we could all achieve that sort of distance necessary to get interested in evaluating the way we make decisions. There is an area that was not mentioned, but I think it's apparent in your past and your present, therefore, and that is religion. Some of the religious sources of our deep emotions are taken for granted as if they are right, and they may be terribly wrong. But getting the distance from them, to evaluate them, check them, allow them to become a resource, a valued resource, instead of the directiveness that is involved in guilt and all those components of religion. It occurs to me that would be a worthy venture. You can almost substitute religion for your word emotion in this presentation. What do you think?
Great question. The question is,
Gloria disagrees.
how does religion,
She has to summarize the question.
Spirituality, maybe?
how does religion and spirituality factor into this discussion? Thanks for the question.
I mean religion. Religion as tradition has blessed it.
Okay, organized, institutional religion.
It's part of our lives because of years we've been into that. And,
With established belief systems and creeds, that kind of religion?
well, yes.
Okay,
And those that have taught us right and wrong.
okay, uh-huh.
That's a source of enforcement as well as challenge.
Religious ethics then, those religious values that have taught us something about right and wrong, arguably inform this kind of discussion. I would argue here that we turn to religion for many things, but when I mentioned how we use heuristics in moral decision making, I contend that we use religious values in the same way. Look at the end of life, for instance. You are there faced with a circumstance of what I call bounded rationality. You could do it with extreme illness too, or genetic decision making too. Here we have bounded rationality. We've got a question we've never encountered before. It's very complicated. There's a lot of uncertainty. We don't know when to accept that further care is futile. We don't know what to do. We really don't know what to do. And we can't get good answers through evidence-based medicine. So what do? Some people would turn to their doctor. Doctor, what should I do? Go to the experts. Some people would say, I'm not going to do anything. I'm going to avoid making this decision. The doctor may turn around and say to the patient, this is your decision, you get to make it. I don't know if I said this before, but I would argue that our reliance on patient autonomy assumes a reliance on patients making rational choices, which I don't think in these very situations is possible, because they don't have the equipment, they don't have the information, the experience, the confidence to make these decisions. In these situations, faced with uncertainty, faced with grave decisions of life and death import, religion can serve as a heuristic. God will decide. I will let God make, I can leave this to God, God will provide a miracle. God is judging me for this thing that I did. I committed a sin here in my past. We get all kinds of religious answers, but people turn to religion, I think, when it's a shortcut. It is a way, again, to avoid the work of making a rational decision. Remember, fast thinking spares you that effort. But religion provides a valid, for some, answer when reason seems bounded by complexity, uncertainty, unfamiliarity. Is that an answer or a partial answer?
Well, a partial one. It does not get at the issue I work with, and that is bias established by religion that is not examined. We don't examine the bias. We assume that's right.
Mm-hmm.
And yet it is a major disruption in the clinical setting at times. But because I'm right, why should I challenge it?
I would argue that with your clinicians who feel they are right, you should challenge it. And that's part of being a professional, that they get to have their assessment. They will fight it if it's a religious-based commitment. But one can say, all religions bring their own set of perspectives here. And you're entitled to your own beliefs, but you can't impose it on a patient. Are you speaking of a patient who claims that they're right?
Well, that's part of the clash of emotional-based thinking that is primarily religious in nature, though we think it is a part of our rational structure of thinking. Mm-hmm. Fast thinking or deep thinking. This is right or wrong, and that's an enforcement factor that we don't often surface sufficiently to examine.
Well, again, I would argue that religion is like a deeply held anchoring heuristic. It's a belief that's very hard to shake because you've held it for so long.
Right.
It's very hard to overcome that.
That's why it's a problem.
Well, any one of these heuristics is a problem. But that's why I'm trying to say, ask the questions, why am I thinking this way? And can I think another way? How else can I see this situation? I'm sorry I can't answer that question more to your satisfaction.
There's no simple answer to it.
Okay. Okay. Yes?
No, and I do think that a lot of people make decisions based on their religious, backgrounds, and that is a source of a lot of our ethical dilemmas for sure. So, but I did have a question, and thank you so much. This was outstanding. I love all the new ideas that you presented, and I am interested in that surface acting and deep acting, and just the notion of how we, can empathy be taught, those sorts of things. And I just wanted to inquire about the fake it till you make it, reflection or statement. And are you suggesting, or maybe were the authors of that concept suggesting that fake it till you make it really, it might not be an effective strategy unless you produce a different response from the patient. Does that make sense? That maybe surface acting isn't satisfying in and of itself to the person who's doing that, but it depends on the response that they get from the patient, and that's what actually can be rewarding and can encourage, maybe the development of deep acting. I mean, does that make sense?
I'm not sure I understand your thought there, but what I would say is that the notion of surface acting as a starting point to get to that empathic connection.
Right. I'm curious about how that happens. Is it something intrinsic to surface acting that comes from the individual, or is it something that has to happen because the response changes? The response is better than the patient.
You're asking, just to repeat your question, I think you're asking about the relationship between surface and deep acting and how one can move to the other. And again, I don't think that we really understand this terribly well unless you reflect on your own experience and think about any encounter in which you've been dealing with someone who might be difficult and with whom you've managed to maintain your composure.
Right.
And if you spend enough time with that person, you kind of start to like them. And you kind of start to care about them. And as you start to understand more about what's going on with them, you start to actually want to work for them. And it's not just about maintaining your composure in the face of an angry patient. It's about, oh, now I really do want to help you. And that's how I would say, starting with the surface acting, pretending interest can lead ultimately, we hope, at least in some cases, to a more sincere feeling for the patient. Does that's how I think of it. Is that
and
answer?
That's how I think of it too. And I just, I guess what prompted the question was that I do feel that sometimes I hear from patients, oh, you know, I feel like you really care about me, you know, but I don't feel that from other people. And so I'm wondering if that transition can actually occur, or if, you know, you will always stay at the surface acting phase unless you get that sort of response back from that patient. You see what I'm saying? So I almost feel like that transition is dependent on the patient response. So if you're good at surface acting and the patient feels like that connection and that they're really, you know, gaining something from the relationship, and then they're responding positively and giving you good vibes and like making you feel good about yourself, that maybe it really relies upon that give and take to make that transition instead of just. I can see if you just kind of hold it on an emotion, and you never get something in return from the patient, that could actually backfire and not lead to you.
You know, it's funny. I disagree. The question is, do you need to have some reward from the patient, some connection from the patient, or a recognition from the patient in order to transition to deep acting? And I'm not sure you do. Yeah, I'm not sure you do. I speak as someone who, I'm just flashing right now, my available example is a student who was very angry with me this year over a misunderstanding. And he was ranting and raving for quite a while, and I felt so badly for him. I got nothing positive from this student for weeks. But I eventually got a thank you. That didn't change my empathy for him. He was trying his best to do something in the face of a lot of difficulties, and he was targeting some of his frustration at me. And I really felt for him. Actually, this isn't a good example in response to you, but it's an example of how my demeanor couldn't express to him how much I empathized for him when he was coming at me with nothing positive. So I just say that as an example of there can be a disconnect between what you're getting for the other person and the fact that you care for them.
Part of the concern I have in contemporary society, particularly in these last 5 to 10 years, has to do with the fact that everything for those below 30 is instantaneous. No, insight not required.
Mm-hmm.
And so we have gone from, rather than talking to each other, like when there is an admission or when there are things going on, to texting each other. We've gone from having statements about what's going on in one's life to 144 characters of pithy comments, usually not that pithy. And as a result, I guess one of the questions I've got is for learners, and you'll be talking to our department on Friday morning, their response to the need to pause and reflect as opposed to do everything not only fast, but Polaroid fast. They don't even know what Polaroid is now, but instantaneously fast. No pause required, no reflection required. If there doesn't need, this is just superfluous. This is, I don't need, I've got my gut, the gut's working fine, don't need to reflect on this, move on fast, because I got something else to do. Just curious in terms of feedback that you've received when you give this kind of a talk to residents or to medical students.
Well, I actually haven't given this kind of talk to residents or medical students yet.
Okay.
But Dr. Duke has just asked a question about the speed with which our younger generations, 30s and below, are moving through the day, suggesting that the speed and the reluctance to slow down and reflect may be a real deterrent to this kind of thinking. It would seem that way, wouldn't it? But I can say, and I discussed this at your conference last year. Do you remember the reflective rounds? In the conference, Dr. Ducas's Academy for Professionalism and Healthcare conference a year ago, I showcased a kind of curriculum that was introduced in our surgery clerkship through a grant from GW called Reflective Rounds. And in that exercise, I was given 2 hours per week with groups of 8 or 9 students for 4 weeks in a row. A total of 8 hours per student in the surgery clerkship, one of the most busy clerkships they have, to sit around a table and talk. And I was paired with a hospital chaplain. And I would say I had resistance for the first 20 minutes. And I explained that this was new, we weren't sure how it was going to go, but that this was their time, and we wanted to explore a number of topics with them. The topics were by week. Where do you find meaning in medicine? How do you experience suffering, boundaries, and self-care? And I did not have a student who did not participate. The conversations were so rich, showing a depth of insight and maturity and compassion and investment and respect for patients and real passion for medicine and valuing of their relationships with patients. I'm sort of getting chills right now just remembering it. They were so candid. I was deeply honored to hear the students say these things. What's more, in their evaluations, they were deeply honored to hear their classmates say these things. They said it was invaluable for them, gave them new hope in what they were doing. They wanted it to be mandatory across the curriculum. They needed this. They needed this. So I would say they may be moving fast, but they have no place for this. Emotional reflection is totally disregarded and dismissed. It's not part of medical culture. I have had medical students who were stuck in my literature and medicine class because they were off cycle somehow and had to take it. And I'm thinking of one right now who was going into emergency medicine, and she was so into doing stuff that it took her like 4 sessions before she could begin to access her emotions enough to write anything. And it was real hard work getting to her, and I just think the train she was on gave her so little room for this that she didn't know how to think about it. I wonder how common that is. You know, that's an elective that self-selects, but I wonder how common that is. Except for these third-year clerkship students in surgery, they could all talk, and they did so with a little resistance at first, but they got over it. To a man, the women were easier, but there was some resistance. You can imagine. Anyway, was there a question back here? Yeah.
I kind of wanted to ask you to continue elaborating that, but specify it. So as a teacher, as a mentor, as a fellow person floating around, individually, how do I help support this? How do I start changing the culture? Because it happens one interaction at a time.
Doesn't it though?
Cultures do not change because I said, look, this is better. It's going to change because I say, I do something differently. So how do you want each one of us to change before we walk out of the store?
Great question. Great question. I wish I had the answer to it because I also come from a troubled medical environment. Our faculty are stressed. We're all siloed. We email the person in the office next door. My advice to myself when I answer your question being, how do we make a difference now, each and every one of us? What can we do? I would say look to the person to the left and to the right of you or whatever, and realize that they're a really interesting person. Maybe it's possible to get to know that really interesting person and care about them a little bit. Find out what makes them unique. Do you know what Dr. Dukas drives? I didn't. I didn't know he was a fantastic singer in his early life, or anything about his really remarkable kids until today. He has, I sort of feel funny about saying this, become far more interesting to me as a result of our conversation this morning. So I think really it's all about relationships. At some level it has to be. We can't change a culture top down. Indiana University, which has put enormous resources into culture change, did it through the bottom up, not knowing where it was going to go, through a lot of affirmative inquiries, small group discussions, trying to find out what people cared about in their work in a large medical institution. They started with the stuff people felt positive about, finding a handful of things they could all sign on to and build from there. I gather from students who've gone there that you can feel it. The culture change has worked. It can't have a pre-described destination. It needs to evolve based on the people there and what they care about. But I think it's worth aspiring toward. Yes?
I had two things. One's quick. It's basically, you've listed a bunch of places where you could draw, places where you could look into to find out more about surface acting, deep acting, that kind of emotional control.
Somewhere in here there's some references.
I just wanted to add residential youth care to that.
Oh.
It's something I've done for the last 2 years. It's not just, I'm not dealing with the patient that didn't follow my instructions correctly. I have to deal with kids on a day-to-day basis that attack me, cuss me out, try to stab me, spit blood in my face, a lot of different things. So there's a lot of surface acting that goes on because, I'm not just dealing with, mild frustrations. I'm dealing with them trying to stab me.
Right.
It's completely different, and I can't show them that I'm angry at them. Sometimes I do, but they are trying to stab me.
That's right.
The deep level acting, when she was asking earlier about whether, you have to have some kind of reward from them, I'm going to say absolutely, but you don't. Because I've had moments where I've empathized with one kid in particular that did try to stab me in the eye with a pen. Because, after a while, all of the aggressive stuff, once you talk to them enough, you realize they're just trying to protect themselves. How do you protect yourself in an environment where people are going to listen to you and respect you and, want to make you feel safe? You make yourself scared. How do you make yourself scared? You try to stab a 6'3" adult with a pen, or you cuss somebody out, or you do something else. So that's the quick part. The second thing is, it seems like when you're talking about culture, are you referring specifically to the culture of medicine?
Today, yes.
Today. How it seems like you can fix the culture of medicine. Say everyone got on board with this tomorrow, and everybody got into the classroom and they did everything. They tried to learn deep acting. They tried to go against their anchors. Everything. When the culture itself, the broader culture and different cultures of the nation that we live in, they tend to endorse emotional lifestyles that are not very supportive of what you're trying to aim for here. Because when, say I was here to be a doctor, I'm not, I'm in medical humanities and bioethics. Say if I was here to be a doctor and I had, I'm going to have 20 plus years of the background culture already there, and I've had to fight it. As a male, I was raised as the stereotypical male. You're not supposed to cry. If you do cry, you get chastised for it. And it's left a lot of, it's been a very negative influence. So I'm wondering, say you're able to conquer this issue in the medical community, do you then proceed to try to influence the culture at large? Because I see the emotional blunting of men as a public health problem.
Wow. The question, if we were, I'm not sure how to summarize that question, but I'm going to focus on the last bit. The question of how to change culture sufficiently to recognize the emotional needs of each of us, even if we were to do that in medical environments, what to do about society at large in which the emotional blunting, which is now, I think that was your word, imposed on boys and men has reached pathological levels. Is that correct?
It's been that way for...
No, is that your question though, roughly?
Yeah.
Okay. I think there are efforts to work on this. I was vaguely aware of Robert Bly's work years ago, and I'm not in touch with the men's movement right now, I'm sorry to say. But I'm assuming if you're articulating this, you're not alone. One contributing factor that I read in the burnout literature was the decline of civil discourse in society now. Just the degrees of anger and stress and the sort of no-holds-barred freedom to express what you're feeling that we have across society now is coming into our hospitals, and you're running into it. So the sort of larger context in which healthcare is trying to take place is what we're dealing with in medicine, just as you're saying it impacts male role identity. Again, I think you can find some small pockets of discourse surrounding this problem. I'm not sure where they are or what they're saying right now. It's fantastic that you mention it, and I think that if emotional self-awareness could include some discussion of our gender expectations, even within healthcare, we might get somewhere. We have the phenomena of people, I really am hesitant to stereotype male versus female providers these days because we find all counts, but you could stereotype what male providers are like, being the real machismo types. I'm not going to call for help even though I'm a first-year resident and don't know what I'm doing, but I can handle this. Or that I'm not going to be moved by the fact that I just saw the most violent coding of someone I cared for a lot. I'm just going to stuff my emotions. We can imagine what men are going through in hospitals that maybe women don't have to hide so much. Are more able. Women may be privileged in some ways, going through medical training in ways that men are not. I'm making this up, but I'm just guessing that there may be some avenues for women to access their emotions, to express them, to seek help, that men may not feel legitimized in doing. I'm not sure if that answers your question at all, but it's what your question made me think about. Yes?
Not even necessarily a question, but to sort of expand the conversation, I think you can help dig yourself out of some of that dilemma by rephrasing it and asking, how can we change the institution so that nobody feels like, male or female, that they have to delegitimize their emotional reactions, right? How can we culturally address this? You can kind of degender it a little bit, and just because some groups may be suffering more doesn't mean that somebody from other groups isn't suffering in the same way. So we see a lot of overlap in individuals that gender differences can kind of extrapolate from, but don't necessarily address.
I sometimes ask my students about their first experience of a death and what happens. And it takes all kinds of forms and times and so on. But students who've had some connection to a patient for whom that death is hard really appreciate it when a nurse says, "How are you? Would you like to take some time?" That the impact is acknowledged. And then there are others who just feel violated when the impact, when the patient has been coded and dies and everybody leaves the room and nothing is said. That is very hard for the sensitive medical student. I had a student going to psychiatry this year who witnessed such a thing and basically said he checked out at that point. Just checked out for a while. Concerning. And I've actually heard from people who work a lot in end-of-life care that they are aware of their own desensitization when they see a lot of dying. They have to remind themselves that for the families of the dying, this is a first time. They see dying all day long, but for the family, how do I remember that for them it's new and extend myself to them because it's new? That awareness is phenomenal. Having that awareness is, I think, the gift that we're looking at here. Emotional self-awareness of where I am. This is no big deal for me, but it is for someone else. And that's common to basically any physician over time.
And it's the next area of research. How do we teach that?
Well, I suggested some of what I've found and some of what I think about, but there's a whole lot to teach. First of all, you have to legitimize its place. We have to use the word emotion in medicine. Yikes, we don't even use it in bioethics. So how do we legitimize the word?
So on that note, we want to thank you so much for your presentation today.
Thank you, David.